I now invite our next speaker, Dr. Vinod Kumar from AIMS, of Professor at AIMS, who always has a huge bag of cases to talk about. Yeah.
Thank you so much, Dr. Anand. Is my screen visible and am I audible?
Yes, please.
Okay, so I'll be talking about atypical manifestations of retinal dystrophies and MACTEL. And I think it's a huge topic because most of the dystrophies present in atypical manner. So I'll try to share a few of my cases. So let's talk about first scenario. We all know about this particular condition, Mizuo-Nakamura phenomena. Typically, when it is associated with normal fundus and preserved vision, we label it as Oguchi's disease, which is a kind of CSNB. Mizuo is nothing but a golden yellow reflex, which disappears after dark adaptation, which is usually prolonged. So if you dark adapt for 2 to 3 hours, the reflex tends to go away. Now, we came across this young male who was a high myope, who presented to us with decrease of vision and nyctalopia since childhood. He could not read any plates on the color vision, and best corrected was 2200 in both the eyes. Now, when I first had a look at the fundus of the patient, I was pretty sure I was dealing with the Mizuo phenomena. But when I look at the macula, I thought, oh no, why this bullseye lesion is there? And which was very well seen on autofluorescence. And this dark reflex, actually we made metallic reflex, we actually made the patient undergo dark adaptation, and this reflex decreased in the both eyes, more in the right eye. Coincidentally, this reflex is better seen on red-free photographs, and OCT of this patient showed selective loss of outer layers at the macula only. This patient underwent full field electroretinogram and showed extinguished rod as well as the cone responses. But interestingly, after prolonged dark adaptation, the rod responses did recover a bit. So we diagnosed this patient as cone rod dystrophy with Mizuo phenomena. And what we learned from this case, when we went into the literature, that Mizuo phenomena is not seen exclusively in Oguchi's disease, but can also be seen in X-linked cone dystrophy and X-linked retinoschisis. Unfortunately, we couldn't get the genetics done in our patient, but over a period of time with wide field imaging, I came to know that while in Oguchi's disease, the Mizuo reflex tends to be panretinal, that is distributed all over the retina. In X-linked retinoschisis, this reflex is seen only in the peripheral retina. While in cases of road cone dystrophy, this reflex is distributed in and around the posterior pole. So to summarize this scenario one, a reflex similar to Mizuo can be seen in other conditions, and clinical picture and distribution of the reflex, however, tend to be different. Coming to scenario two, we came across this 24-year-old male who presented to us with decrease of vision in his right eye for 1 year. The best corrected was 2400 in the right eye and 2030 in the left eye. Now, the right eye showed a full thickness macular hole and a yellow deposit peeping through it, with the surrounding retinal detachment, which was limited to the posterior pole. While in the left eye, we had a typical presentation of the vitelli-eruptive stage of the Best vitelliform dystrophy. We went ahead with the ERG, which showed depressed responses, EOG, sorry, which showed this depressed responses in both the eyes, and we diagnosed this patient as Best vitelliform dystrophy. This patient underwent surgery with the inverted ILM flap. The patient did well and improved to 26C after the surgery. Now, a month later, we came across a similar patient where, again, we had a macular hole RD in one eye, and other eye had a vitelli-eruptive stage of Best vitelliform dystrophy. This patient, again, underwent surgery and did well, and we reported our series. And in fact, the similar success had never been reported previously. Interestingly, 2 years later, we again came across a patient, and this time we could get genetics done. And this was a patient of autosomal recessive Best retinopathy who presented to us with macular RD in the right eye, and left eye had sky-like picture, which was a clinical clue to the diagnosis of autosomal recessive Best. Now, again, we reported this patient. What we learned from this scenario that after myopia and trauma, Best vitelliform dystrophy is a common cause of macular hole associated retinal detachment. Moving on, coming to scenario 3, we came across this girl, which was a 7-year-old at that time. She presented to us with decrease of vision for 4 months. The best corrected in the OD was 120, 120, while in left eye, she was finger counting. What was astonishing was there was a massive retinoschisis, which was present in almost inferior half of the retina, while we could see the retinoschisis in the superior half as well. The OCT did confirm the retinoschisis in all over the retina, while in the left eye, this schisis progressed and had involved the macula as well. Now, we did get the full field ERG of this patient, which was negative, which did suggest a diagnosis of XLRS in this patient, but we were hesitant to make a diagnosis in a female child. So we went on to screen the patient, parents of the patient, and interestingly, the father of the patient showed a very typical picture of X-linked retinoschisis. We went back to the literature, and there are several hypotheses which explain why a X-linked recessive disease can occur in a female patient. So there are very few reported cases in the literature as well. So what we learned from this case patient was that X-linked disorders, especially XLRS, is definitely a possibility in females, and relatives must be examined to establish the diagnosis. Coming to scenario 4, we had a young male again who presented to us with nyctalopia since childhood and decrease of vision in both eyes for 1 year more in the right eye. In the right eye, this is the color photograph. We had extensive intra and subretinal hard exudates. There was a neovascularization of the disc on ultra-wide field FA, and not many details were visible. But the left eye posted a better picture where we had a typical picture of retinitis pigmentosa and infratemporal exudation along with bulb-like telangiectasia, and picture somewhat going into vasoproliferative tumor. So this patient we diagnosed with retinitis pigmentosa with Coats-like response, and we treated left eye aggressively. But in spite of 1 year of our treatment, 3 Avastins, 2 triamcinolone acetonides in the vitreous cavity, 1 Ozurdex, and multiple sittings of laser photocoagulation, this patient kept worsening and went down to 3/60. It is at this stage we decided to go ahead with the surgery, did a PPV, released all the membranes, and did extensive laser photocoagulation. The patient did improve to 6/60 in the immediate post-operative period and was stable a year later with visual acuity of 6/18. So Coats-like RP has been described in up to 3 to 4% of the cases, but it is seldom so aggressive. But what we learned from this case is that PPV may be a viable option in cases that fail to respond to conventional treatment. So this is my last scenario. Again, I'll be presenting 2 cases here. Case 1 is of a 60-year-old male who presented to us with decrease of vision in the right eye. The patient was hypertensive. The best corrected in the right eye was 6/36, while in the left eye it was 6/9. Now on fundus examination, the picture was very typical of mactal type 2, where we could see the perifoveal pigment plaques in both the eyes. But what was peculiar was intraretinal hemorrhages in the infratemporal quadrant, which were away from the fovea. Autofluorescence did confirm the scattered RP changes, and we could see a hyperautofluorescent lesion as well. We did an OCT, which revealed changes typical of mactal type 2, as well as a fibrovascular PED, which was there infratemporal to the macula. And the left eye again confirmed a diagnosis of mactal type 2. Interestingly, the ICG of this patient revealed typical polyps, which were there in the infratemporal quadrant. So this patient was diagnosed to have mactal type 2 and PCV in the right eye, and left eye made diagnosis of pigment epitheliopathy, pachychoroid pigment epitheliopathy in view of the pigmentary changes. This patient went back to their parents' institute for further anti-VEGF therapy. A similar case was seen by us sometime later, 42-year-old male this time. Again, we had perifoveal pigment plaques and serous PEDs. And when we did imaging of this patient, we could see perifoveal leakage because of mactal and pooling in the PEDs. Left eye again had a typical picture of Mectel with intraretinal crystals, right angle venules, and perifoveal gleying. And this patient again had some RP changes scattered here and there. So this patient, again, OCT showed a thickened subfoveal choroid with virtually obliterated choriocapillaris and serous PEDs. However, there was no evidence of CNV in this eye as well. So at the same time, Dr. Spade's group reported a paper where they described concurrent MACTEL and CSR, and they concluded that co-diagnosis of CSC and MACTEL type 2 should be considered in atypical presentations of both. And then we went ahead with our paper and we described our findings of pachychoroid spectrum of disorders in MACTEL type 2. In fact, from this, we got an idea and we analyzed the choroidal thickness in MACTEL eyes with the controls. And we did find that MACTEL type 2 patients actually had thicker choroid as compared to the controls. So what we learned from this, that MACTEL may be associated with thicker choroid and pachychoroid spectrum of disorders. So this is summary of my cases. Thank you very much for your patient listening.
Thank you, Dr. Vinod. And I'll invite Dr. Jay for his comments on MACTEL and pachychoroid. What is his take on that?
Thanks, Vinod. As usual, amazing cases. And yeah, I believe that now we are going to link, we are going to see more and more pachychoroid, or we are going to see more and more choroidal involvement in many of the diseases. And I have seen those papers, and some of the papers are clearly showing that there is a presence of thicker choroid. The biggest challenge is that where does this choroid plays a role in MACTEL? That is still unclear, because MACTEL, considering primarily in a inner retinal or retinal vessel disease, we are still uncertain whether it is the choroid is playing a role or not. However, having a concurrent CSCR with MACTEL, this is something which is becoming more and more common. I myself have seen a patient similar to that, where we saw the pigmentary changes and the cavitary changes as we see in PFT. But overall, fantastic collection.
Any comment from Dr. Anita?
I think those were excellent cases. My the best disease with macular holes. I think I might have reviewed one or two of those ones, and ARB. I agree. And the only one that the retinoschisis was the most interesting of all of them. The other ones you can easily explain, but you know, a 7-year-old girl with such extensive retinoschisis, I guess it can happen with lionization. Was genetic testing done in that child? Was there other family history, extended family history in previous generations about X-linked inheritance? That was my question for Vinod.
Sorry, I couldn't get that.
I said in the kid with the extensive X-linked, extensive retinoschisis, I don't know if I could call it X-linked yet. She was only 7 years old. You know, most of the X-linked diseases, if they occur in women, they occur much later in life because of the lionization. And unless you have severe lionization, that, I guess it's a little hard to think that can happen. But most X-linked diseases that manifest in women occur later in life, any of the other X-linked diseases. So I know you examined the dad, but was there any other extended family that you could ask about maternal? Because, you know, it should come theoretically maternally inherited for the X-linked diseases and goes to the guys, but because the father could give it to the daughter. But unless you did a genetic testing, it's hard to sort of think that that is X-linked foveal schisis.
Yeah, I agree fully to that. But the literature review we did, and there were a few similar cases where the father had features of X-linked retinoschisis, and all of them actually had very severe disease in the female.
Right, but did you do genetic testing?
No, that is the only flaw. In fact, I mentioned that we couldn't get the genetic testing of that patient. Yeah. And unfortunately, the patient was from a very far away place and we could not get other family members.
Was there more family history, like in the father's previous generations, like two, 3 generations? Unless you can really get that, it's hard to think that that is X-linked foveal schisis, especially the father having milder disease and the girl having more severe disease. That's kind of unusual too.
Yeah,
So I
yeah,
would still hold my judgment on that one.
yeah, I think because even father did not that he was having any eye disease in the initial interactions. We just took the history, and the father denied that he had any eye problem. But when we were stuck with the diagnosis, we actually examined him, and we found that he had the features of X-linked retinoschisis. Unfortunately, the patient was from very far away, from a different state, and we could not get other family members to come in.
For the future, these cases, you have to do a segregation analysis, doing the mother's genetics and the father's genetics too, if you really want to tie it up. Maybe the mother's a carrier. You never know. It might have been sent through the female. This one, that's why the kid has a severe disease. It's a little bit unusual for that to occur in a 7-year-old girl. So I would hold my judgment on that. It could be that the mother is a carrier. I mean, sometimes, these X-linked diseases carried by the women in the family and nobody else has it. And then the father maybe has the disease. And so maybe that's why the child has such severe disease. It's hard to just say it with just lionization. But that was a really good case. And I agree with the fact that the Mizuho phenomenon can be seen in other diseases. I mean, I personally have only seen one patient with Mizuho phenomenon. It was in a kid with young African-American male with retinitis pigmentosa, and cone rod, actually was cone rod. And otherwise, I've not seen one. And I don't have much experience about that.
Thank you so much. Thank you.
So terrific. I mean, a wonderful discussion. We could keep going on.